Today we will be discussing a case scenario of a 38 years old male who presented in the emergency department with complaints of the chest pain for the past 4 hours. This was the ECG that was done at the time of the chest pain. So we have to rule out some causes of the chest pain in emergency. First of all, we need to see whether this is myocardial infarction or not. For that, we have to obviously comment on some changes, especially on the STs. So we can see that there are some ST changes. There we can see that elevations are being seen in the inferior leads and also somewhere in the chest leads as well. So now we have to be sure that this is not a myocardial infarction, or is it myocardial infarction? Okay, so this is the main question that we need to answer. First of all, let's define the ST segments. We can see that these are the concave upward ST segments. You can see it in the inferior and the chest leads. However, we cannot see any reciprocal changes. So for an MI, usually the reciprocal changes are present. But this is not the case over here. So we can see the chest leads, the lateral leads, that there are no ST depressions. The T waves look a bit prominent. Now obviously in the early stage of MI, the T waves usually are hyperacute or prominent. Now is it the early phase of the MI or this is something else? Let's move ahead. We can see that there is a notching at the J point, and that is being seen in the chest leads predominantly. So let me zoom one of the leads. Here we can see the notching that is more prominent in especially lead V3 and V4. So this is the end of the QRS, and this is basically a J point over here that is being elevated, producing ST segment elevation, and this is in the form of notch. So it has a specific pattern that we call as fish hook appearance. So now this is a fish hook. As a reference, we can see that those who go for fishing, they use this hook to catch the fishes. So now if we can see the shape of this resembles a shape like this as well. So it looks like a hook, and this is called a fish hook appearance. In addition, we know that there are some differentials of myocardial infarction. So for that we also need to evaluate for pericarditis as well. So for that there is a value, and that is an ST and T wave ratio in the lead V6. So we have calculated that ratio, and that is less than 0.25. So anything that is above 0.25 will suggest pericarditis. However, we can see that there is hardly any ST segment elevation, and the T wave is definitely somewhere around 5 to 6 mm. So the ratio that was calculated was less than 0.25. So this is going against pericarditis, at least in this value. So far we have managed to see that there are no specific appearance or ECG findings specific for myocardial infarction, and also there are no proper features on the ECG to suggest a pericarditis. So this was a case of an early repolarization. So what features of the early repolarization can we see on the ECG? So there are ST elevations which are dominantly seen in the chest leads. just like in our case, along with the prominent T waves. Now, the changes for the early repolarization will remain static in contrast to the myocardial infarction, which is usually dynamic. And with a slow heart rate, the early repolarization changes become more prominent. So, this is very important, especially when you are seeing the patient and doing the sequential ECG. If you happen to see that by any chance the heart rate goes down, these changes usually become predominant. So be wary of that as well. The important findings are that there is slurring or notching. So here we can see that there was a notch here. So these notches are very important, especially when you are trying to identify an early repolarization pattern. Sometimes there can be slur seen as well. There will be no PR depression, especially in the case of early repolarization. And if it is present, then pericarditis should be think of. And the progression of the R wave will be normal, as we can see it over here. So there is not a poor R wave progression. So these are good healthy R waves. This helps to rule out myocardial infarction, especially in the late phases. And cardiac biomarkers will definitely be normal in such cases. T waves in the case of early repolarization have some features, and these can mimic some of the other differentials as well. So in the case of early repolarization, these T waves are asymmetrical. So this means they have a upsloping that is a bit slowish and the rapid downslope over here. These are peaked because you can see that this T waves doesn't look to be pretty normal, so they have a high amplitude as well. They have to be concordant with the QRS. This means if the QRS is positive, then the T waves also have to be positive. So they have shown a concordance as well. Now, in early reposition, the studies have shown that usually the precordial leads will show a 6.5 mm on an average amplitude of the T waves and 5 mm in the limb leads. And we can see that these are almost touching these values over here. Now, very important aspect, especially in the case of ST elevation. So whenever you want to identify whether the patient is having a myocardial infarction or an early repolarization or some other differentials based on ST elevation alone, then you have to see certain things. So for an early repolarization, you can see that this is a upward concavity of the ST segment, and it is marked by the simile that the face is kind of smiling just like this. So this is concavity upward. Okay, here you can see it over here. So this is upward concavity, while in the case of myocardial infarction it is downward, and obviously the face is showing to be a sad face, and that's why this favors a myocardial infarction. But do remember that it's not always the case. Sometimes the patient might have been having myocardial infarction and will be having a concavity upward. So you always have to remember this feature regarding myocardial infarction. Mostly it will be a convex, but sometimes it can be a concavity. So we need to correlate with these changes, the history, the presentation, and the other biomarkers to rule out a myocardial infarction. Now, finally, some points to remember, especially in the case of early repolarization. So it's a common variant, and this is a normal physiological ECG pattern. So you have to remember that, because you have to differentiate this from other serious fatal issues like myocardial infarction. This can be seen in female and male of all age groups, and 1% of the population worldwide are said to have this early repolarization pattern. The ECG features, although they mimic some of the other features, but they also have their characteristics findings, that are the notches and the fish hook appearance. The ECG changes get prominent with the bradycardia, and this usually, although doesn't require any treatment in majority of cases, but this can be a cause of a sudden cardiac death in some of the cases. So those are some features which I will be discussing in another lecture, and we will be discussing those high risk features for the early repolarization. So that's why it's important to remember this features of early repolarization, although they are benign in majority of the cases, but rarely these can be sometimes dangerous as well.